Good evening. Good morning, actually. I'm Dr. John Bennett, broadcasting from Miami. We have here another presentation in the conference for the pediatric neurosurgery, the collaboration of Neurosurgical TV with the Department of Neurosurgery of the AIIMS Hospital and Deepak Gupta of the Department of Surgery. Today, we have the pleasure of having Dr. Sridhar Krishnamurthy, neurosurgeon from India. He's going to talk about surgery for brainstem lesions in children. I'm sorry we're a little late, Sridhar, but take it away.
Yeah. Okay, let me share my presentation with you.
Okay. There you go. There you go.
Okay. So, what I'm going to be, so can I start off?
Yes, please.
Okay. So, good morning and good afternoon, depending on where you're seeing this and when you're seeing this. I'm going to be talking today on brainstem lesions in children and surgical considerations on those lesions. I'm coming from a city in South India called Chennai, previously called Madras, and that is here, marked in red. It boasts of a lovely beach, which is supposed to be the second longest beach in the world, and also has a lot of history dating back almost to the 7th century AD. So that's where we are from. Coming to the brain stem, just a little bit. Yeah. The topic of the brain stem is for two reasons basically, and the problem why brain stem lesions have been in the middle of a lot of discussion is basically because it is compacted and densely packed with nerve fiber tracts and cranial nerve nuclei. This is, you can see the cross sections of the different parts of the brainstem on your screen, which shows the dense anatomy, and this is why people have been worried about operating on the brainstem. This is other than the fact that the brainstem is generally, it's actually situated right in the center of the skull and bounded in front by the clivus, and it's not really easy to get to. So you have an approach which is not very easy, and then you have a structure which is full of fibers and nuclei which you really don't want to damage. So surgery on the brainstem has been considered for long, till about a decade ago, not really worthwhile. But a lot of technology change, especially radiology, MRIs, and also monitoring intraoperatively, that and the understanding of different types of lesions has helped change this thought. And now we seriously look at being able to operate on these lesions. So what is the role of stereotactic biopsy before we go on to actual surgery? Now, still the role of stereotactic biopsy is basically for very small lesions which don't reach near a surface or near a pile surface, and the track that you use is either a transcerebellar approach or a transfrontal approach. But generally speaking, the stereotactic approaches have now given way to more microsurgical approaches where we can remove the lesion. So the approaches which are generally used depend on where exactly the lesion is. It may be a subtemporal, it may be retromastoid, or maybe a midline posterior, depending on where exactly the lesion is with respect to the brainstem. But the most important, I think, point is how do you know where to enter the brainstem? And this paper from Spetzler's group way back in 1996 showed that, and it was the two-point approach where you place a central point on the lesion and then take that point to the pile surface closest to you, and then if you extrapolate that line, that would be how you would approach. So if you take the center point of the lesion and then take the point right next to it on the pile surface, and then therefore this lesion would be approached this way. So I think that is why, that's how you would do it on the brainstem itself. Otherwise, there are other guiding points which you would have. If there was a bleed, you would have discoloration of the brainstem surface. You would sometimes have a grayish discoloration if there is a subpile lesion which is abutting the pile surface. Now, the common presenting symptoms and signs are well known. They include double vision, which is very common, weakness, imbalance, and basically difficulty in swallowing, headache, drowsiness, etc., which show either affection of the cranial nerves, or it shows raised intracranial palsy and involvement of the long tracts. Now, some of the common clinical findings, you normally would suggest a triad of cranial nerve deficits, long tract signs, and ataxia. You may also have papilledema. Sixth and seventh nerve palsies are common. You could have a trigeminal palsy as well. Now, sometimes you could determine where the lesion is looking at this clinical signs. And for pontine gliomas, you could have infants and children with failure to thrive. If you have an involvement of the third or fourth nerve, you look at a mesencephalic component, and hydrocephalus is common with periaqueductal or fourth ventricular outflow lesions. Now, this is a typical example of a lesion with a
Are you okay, Sridhar? I think we froze a little bit. Are you there, Sridhar? Hello, Sridhar, are you there? Shit. Damn. Just wait a second. How you doing, Omar? Is it me?
No. I'm here.
Oh, okay. Are you here?
Yeah, I'm here. I can hear you all fine.
You can hear me, okay.
Yes.
Okay, Omar's coming back.
Yeah, Dr. Mars.
Sridhar, I think may have to bounce out and come back. There's probably Wi-Fi is frozen. How you doing, Omar? Can you hear me?
Hello, John. How are you?
Hey, how you been? Long time no see.
Yeah, sorry, I was very busy the last 2 months.
Yeah, you're having network issues, huh?
Yeah, no, I have some network issues. I don't know why. I even tried to use this is Wi-Fi issues.
Yeah.
I tried even to connect through 3G. It's okay, a good connection, but we cannot do any customization to the screen. I just can watch and chat.
Oh, okay. So how's it going in Iraq?
It's okay.
It's okay.
Stable,
Very good.
as possible. Yeah.
Very good. Yeah, we're making progress. This is a
very great. It's very nice. That's Indian Pediatric Conference. It's really very great presentations.
Yeah, we had like a 2-day pediatric neurosurgery.
Yes.
And in Latin America next month we're doing one on pediatric neurosurgery. We have a full schedule. Soon we'll be in Iraq. Soon we'll be in the Middle East doing conferences.
Yes.
But we find that's a good way to get everyone together.
Yes, that.
And Slaven is head of Dandy in Croatia now.
Just a moment.
Yeah.
You can hear me. Okay. My cursor froze. Hello, Dr. Amar. It's very nice to see you.
Yeah,
I enjoyed your. Yes, I enjoyed your travelings, and I saw that post which one neurosurgeon said that you were holding his book, and I think it's really amazing.
He was a patient. He's a patient that has a big support group.
Oh, that's even more.
Excuse me, Sridhar back. Okay,
Yeah,
Sridhar.
sorry.
Hello, Sridhar.
Hi. Sorry, my internet suddenly crashed.
Okay, that's okay. It happens. Just continue.
It happens to all of us.
It happens. It happens everywhere. It happens here in Miami too.
So I was on right through Sarat's.
Okay. Okay.
Yeah, starting screen share.
Okay.
Okay. So, okay, here I am. So here we are seeing a cervicomedullary lesion, and here you're seeing a quadriparetic patient who's flaccid in his upper limb and can't move his upper limb at all. And this is some of the clinical signs that you will come across. Historically, uh, uh, most surgeons thought that it was a hopeless problem, though some of them still tried to operate it. It's only in the last decade or so that people have been thinking of operating on brainstem lesions seriously. Now, if you look at the epidemiological findings of brainstem gliomas, they form approximately 10 to 20% of brainstem tumors, and 75% of all brainstem gliomas occur in children with a mean age of presentation of 6.5 years. Most of these gliomas are the diffuse type, and many of these focal lesions occur in the midbrain. Now, the children with diffuse brainstem gliomas present acutely with a short history, and the prognosis is poor. And radiation and chemotherapy, though, have been the mainstay. They have not changed the prognosis very much. And in a recent paper, even temozolomide has not been found to help in the therapy. Molecular biology, there have been many findings recently of a mutation of P53 and amplification of a mutated EGFR, but none of these have translated into clinical care. There has been a new entity which has been defined as a diffuse midline glioma. Also, there have been two different types of diffuse brainstem intrinsic pontine glioma described. One of glioblastoma and one of an oligodendroglioma, but these two have not been translated. Finding these have not translated into clinical care. Now, if you look at the classification systems, basically it started off with Epstein, who defined these as either intrinsic, exophytic, or disseminated. The intrinsic were either diffuse, focal, or cervicomedullary. And then came the CT scan classification into 4 groups. Again, the group 2 were the intrinsic tumors, which were again defined into the hypodense non-enhancing and the hyperdense enhancing exophytic ones. MRI then came into the 1990s, where there were different classifications which came into play. But I think it was this classification in 2000 which combined both the CT and the MRI, classifying the brainstem lesions into 4 types: the diffuse, the intrinsic focal, the exophytic focal, and the cervicomedullary, which gave it some sort of a focus and showed how these could be looked at. This landmark paper in 2009 by V.S. Mehta and Sharat Chandra, who spoke just before me, is also a co-author in this, proposed a modification classification and gave some sort of a thought process on which of these tumors should be operated upon. And they classified these into the intrinsic, expanding, diffuse, and the ventral types. And what they said in their algorithm was that the diffuse lesions, if on the MRI you found a diffuse lesion, you would not offer a surgery or biopsy. You would either do a shunt or an ETV as required and then refer for chemotherapy and radiation therapy. In their opinion, ventral lesions perhaps should also be referred for direct radiation chemotherapy, but presently this is not the thought process with the development of new microsurgical and skull-based approaches which have been found where you can approach these ventral lesions. Now, if the MRI were not either diffuse or ventral, then came these other types, all of which underwent surgery, and then, depending on the pathology, underwent definitive therapy. Now, I'm going to take you through different types of tumors and see what happens to them. Now, this is a 6-year-old boy with vomiting and internuclear ophthalmoplegia. the CT scan showing a diffuse infiltrative pontine lesion. Now, the MRI also shows the diffuse pontine lesion. A critical finding in this is the basilar artery being almost surrounded by the tumor and the vessels all being engulfed by the pontine lesion. Enhancement with contrast of these can be variable, and you may find it in patches all over the tumor, and that is not relevant to the pathology. All of these are high-grade lesions, and the prognosis is not good. And maximally, you could just offer the child an ETV or a shunt surgery. Another case, an MRI in the plain study showing a diffuse lesion, but the contrast study actually showed it to be a circumscribed lesion as like this. Now, this would be a candidate for surgery to excise the lesion. An interesting case which highlights what we have just said is a 4-year-old male child brought with history of sudden onset weakness of the right lower limb, followed by the right upper limb, drooling of saliva, and slurring of speech. A scan was done, MRI, which was reported as a pontine glioma, which is fairly true, extending a little higher up to here. But the consulting surgeons then decided not to do anything and referred the child for direct radiation without a biopsy. Towards the end of radiotherapy, the child developed an increasing weakness and vomiting, then gradually became bedridden, drowsy, less responsive, not taking oral feeds, and then was advised by the oncologist palliative and end-of-life care. And that's when they came to us, and when he was examined, the child was sick and malnourished with a very poor Glasgow score, a 7th nerve palsy, lower cranial nerve palsies, hemiparesis, and bilateral plantar extensors. An urgent CT scan showed gross hydrocephalus. You can see how big the ventricles are, and therefore for an immediate shunt surgery was done, following which the child improved in his sensorium, but the cranial nerve and long tract signs did not improve. An MRI was repeated, which showed an increase in the size of the lesion, and therefore the child was offered surgery, and that was what was done. We did a midline suboccipital craniectomy, taking out C1 because there was tonsillar herniation in the MRI, and we went split the lower end of the vermis. This showed the bulging brainstem there. The tumor was then removed using CUSA, and it was a very avascular, tough lesion which was removed. Intraoperative monitoring was used, which did not show any change during surgery. So was BAER used with no change between the baseline and the intraoperative and postoperative findings. Postoperative, we had showed that we achieved radical excision. The child gradually improved, and this picture is about 3 months post-op, and now the child is doing very well. But what's interesting is the pathology report, which just showed necrotic tissue with acute inflammatory cells, raising the possibility of one of two things. Was it an inflammation pathology that it was all along, or did the radiotherapy create the inflammation but with necrotic tissue and inflammatory tissue? But the pathologist was not able to find even one tumor cell in all the sections studied. So the point to be noted is what may look malignant, highly malignant on an MRI or a CT scan, but can be removed, should be removed, because it may not actually be really malignant. Another example of a brainstem lesion at a different location, a 15-year-old lady, a girl with headache and upward gaze paresis. This is a typical location for upward gaze paresis. This is a tectal lesion, but the patient had headache and signs of raised ICP, and therefore we operated. We used the infratentorial supracerebellar approach for this lesion, and this is the video. This is the back of the brainstem. We have already retracted the cerebellum, superior part of the cerebellum down. This is the dorsal surface of the brainstem. Make a small cortical opening there. John, are you able to see the video properly?
Yes, we can see the video. Looks
Yeah.
excellent. Looks excellent.
We can't see it, but
Okay.
slow, but okay.
So the gray lesion is just under the pia. It has a good cleavage plane, and therefore using microdissectors, the lesion is dissected off. It is then taken out piecemeal. We don't take it out as a whole, so it is taken out piecemeal. And there, slowly, you can see the top of the aqueduct, and as dissection proceeds and the tumor is removed, you could actually see the right into the fourth ventricle from the top. This is where one has to be careful, because one should not dig in to the normal brainstem tissue. One should be very careful, use microdissectors, follow the cleavage plane. And this is looking into through the aqueduct into the floor of the fourth ventricle from the top. And here we have achieved a radical excision. And the post-op scan shows that we have removed the tumor completely. The pathology was a pilocytic astrocytoma, which is a benign lesion, and therefore, in a sense, we have cured the patient of her brainstem lesion. Now, we must remember that very often, as neurosurgeons, we see aqueduct stenosis. And if we see aqueduct stenosis, please watch out for the small hypodensity in the CT scan, which may show up as a tectal glioma later in life. Now, this is just a point to note, because we don't often look at that. We just assume that it is a aqueduct stenosis because of a congenital web. Remember that it may be a tectal glioma. These are some other examples of lesions which can be removed. This is like a 7-year-old girl with left hemiparesis, raised ICP, which this can be removed. It is circumscribed and it can be removed. So can this. Now, this is not a child, but this is just to emphasize how much one can do in brainstem surgery. This is a 30-year-old lady from Yemen who developed at 6 months of pregnancy left-sided weakness, double vision, and progressive drowsiness. And when she actually came to us, she was E1M1, requiring ventilation. And this was her scan, which was extending right through the brainstem into the thalamus. So it was going up right up to the thalamic region, extending right down from the lower end of the pons, almost right through up. This is showing the sagittal and the coronal cuts. So we did the same approach. We did a suboccipital craniectomy in the midline, and in these huge cases, I would like to do a craniotomy which takes off the whole of the midline, right from the transverse sinus right up to foramen magnum. I also remove C1 so that the tonsillar herniation here is taken care of. I just
Okay, did we lose him again?
I'm sorry, my videos are not working on the presentation. Checked it
Okay,
this morning.
it's okay. That's all right. It's all right.
Yeah,
Just keep
I
working at it.
So this is how we were. Can you see this video?
Not yet. Not yet. Keep.
Okay,
You're
sorry.
not sharing it. You're not sharing it yet.
Okay.
Yeah, it'll take a while before we learn this technology. There you go. There you go. Okay,
So,
good.
So I'll just, this is using the CUSA on the tumor. And the most important thing is the dissection of the normal white matter of the brainstem from the lesion. Unlike the cerebrum, you cannot really remove. And this is a technique where you take your finger off the suction and use it like a microdissector to push the white matter away from a circumscribed capsule like the lesion. So once that is dissected off, and then you can use your CUSA to further debulk the part which is dissected off. And I think this is a technique which I think I would like youngsters to see. Let me get back now.
Okay. You're off the screen here now.
Yeah. So this is at the end of the surgery where you're actually looking at here the fourth ventricle and the aqueduct from below. This is all the tumor bed, tumor has been removed, and here you're actually looking at the aqueduct from below. In the other case, you saw it from above, and here you're looking at it from below.
Okay. You're back off.
So
there you go. Okay.
So once again, intraoperative monitoring, no changes during surgery. PAER, no changes during surgery. Post-op scan shows no real tumor, a little bit of blood around the edge, which comes to say that even large tumors going right up to the thalamus, provided they are circumscribed, can and should be removed. And I think this is a very important message which I think I would like to give in this meeting, because very often we see people shying away from removing these lesions because if you don't remove a tumor, irrespective of pathology, patient has no chance. This was an anaplastic oligodendroglioma with lipomatous differentiation. Patient has received radiation. Patient is now communicating, is now off the ventilator. She is moving her limbs and is on rehab, learning how to sit and stand, which for the relatives is a fantastic thing because they want the patient to become much better. And we have now followed the patient now for 3 to 4 months, and the patient is now still doing well without a recurrence. So this is I think a great lesson that we all learned because we never thought that the patient would do so well. Now this is a child who came with this lesion many years ago. This was almost in the late 1990s with this lesion. Looking at the lesion, we were sure that it was a tubercle, but antituberculous therapy did not help the child. The child progressively developed signs of raised ICP, as we can see. Why? Because the child has got hydrocephalus, and also child developed neurological signs in the form of hemiparesis. The question was, how do you approach this lesion? And this is something which is ventral. You really cannot approach this lesion from the back because there's a huge amount of tissue here. Therefore, we would have to approach the lesion from front. And then when we were discussing it, we came to understand that it was one of us who came to ask the question as to why we could not use the ventricle as a route to approach the lesion. Generally, in neurosurgery, the dictum used to be is not to cross too many pile boundaries as you approach lesions. But here we thought we could use the ventricle, and then when you study the anatomy, we realized that the choroidal fissure of the temporal horn was very close to the lesion, and therefore that is what we did. I'm going to show you this video. Again, I'm going to go to that video and come back. Can you see this screen now?
Yes, we can.
Yeah. So this is an old video recorded on a VCR. I don't know how many of the people watching it
That's a while ago.
know about VCR. So it was on tape. So this is inside the ventricle here, and it's one of the old microscopes. And here we are dissecting the choroidal fissure to reach the side of the brain stem. And once we dissect that, we get onto the side of the brain stem, and open the pia of the brain stem there. This is basically on the anterior aspect of the brain stem. And voila, there was the lesion. And this is tuberculous pus, which is this whitish pus here was this tubercle. And this whole thing was drained. Of course, it was taken for culture. Then he was continued on antituberculous therapy. So this is sometimes you would have to think differently as to what would be the best way to approach these brainstem lesions in children, because you don't want to sacrifice too much of either any sort of tissue which would be vital for the child as they grow. And that was the capsule of the tuberculoma as it came out. This was the post-operative scan, and this was the child 10 days later. So that was the post-op scan, and this really showed us that we sometimes need to think out of the box, look at the anatomy of the brain, which allows us to reach areas which we think are not accessible or we can't reach. Now, I showed you that clinical picture of the boy with the cervicomedullary lesion, and once we operated, look at him. He's standing. He's able to lift an arm and become functional again. And that's what surgery on the brainstem does. And I think it's very important that we do this and not just shy away from these lesions. So as far as the brainstem gliomas are concerned, I think they're a spectrum of tumors, and surgery with excision should be performed as the pathology is variable. And the diffuse infiltrative pontine lesions are the only tumors to be treated directly with radiation and chemo. Ventral lesions too can be removed, but you need to think how you should approach these lesions. I'm just a little bit through the cavernomas, which are also a main lesion in the brain stem. And the problem is that they have a high propensity to bleed, especially in children. And therefore, it is essential that these are removed when you find them in children. As far as the literature is concerned, the current clinical management shows that we can now operate with excellent results, and the preferred route has shifted from a dorsal to a lateral approach. So surgical management is offered for cavernomas that reach or are just below the pile surface, and all patients that are symptomatic and have had a single bleed. You do not wait for them to have multiple bleeds, especially in children. Early surgeries are now the dictum. Now I bring to you another case of a 1 year, 3 month boy with progressive left hemiparesis, left third nerve palsy. As you can see, this is a lesion which is multicystic. I'm just going to increase the magnification of it, and you can see that in the sagittal pictures that there is a fluid level, which means that there is some sort of a fluid which has settled down and the solid state has settled down, and this is what was the lesion which we were presented with, and therefore we decided to approach this through the retromastoid unilateral supracerebellar sort of approach, where you could reach on the superior surface of the cerebellum to reach this part of the lesion, as well as laterally to reach the part in the CT angle. So this is what we found. This is the 7th, 8th nerve here, the 5th nerve. It was anterior to the cranial nerves. So this was a dark colored cyst covered by arachnoid and then pia. So we collected that. It was fluid blood, and therefore we knew we were dealing with a multicystic giant cavernoma. Now, the problem with these multicystic cavernomas is that the wall is almost just like arachnoid. So you would have to be very careful in peeling this off and separating it from the brainstem tissue. So this you would have to do very gently and take it along. The main issue was that it was right anterior, and we kept going till we could see no more. We put in an endoscope. We realized that there was tissue somewhere around here which was there, but I was not confident in taking that out through this approach. I thought I would damage the child. So we left the surgery at this, and we decided to come back after about 4 to 5 days once the child had recovered from this initial surgery. Unfortunately, the child bled in the interim period, and we had to go in as an emergency. So this we then approach through the midline, through the midline suboccipital approach. We did an inferior Vermian section, and we reached the hematoma and took out the rest of the cavernoma, and that was the whole defect after the surgery was done. This was the immediate CT scan, which shows the approach here and the approach there. Retromastoid and the midline shows no cavernoma left behind, some edema in the brain stem, secondary, I think, to the bleed. This hello? Are you able to see me?
Yes, we are.
Okay, fine. So this shows the MRI at 9 months post-op, which shows no residual cavernoma, and this is the child immediate post-op, and this was at about 2 years post-op. The child is doing well, going to school. Now, what we learned about this, because what shocked me that small bit of cavernoma which we had left behind in the brain stem, which we could not reach, bled almost immediately. And it says here in literature that the incidence of rebleeding is highest within a month after surgery. And more, not only that, there is a paper which also says that multilobar cavernomas with a thin wall and satinite nodules are more prone to bleed. Now, this then was a learning curve for all of us, so that I'm sure the next time we get a lesion like this, we won't leave it behind, but we would go in at the same approach through another, same anesthesia through another approach and take the whole thing out. So the lesson learned from this is that never leave a piece of the cavernoma behind, especially in children and especially when they are thin-walled, because it could lead to a high risk of rebleed and a disaster if you're not careful. So the take-home message on brainstem cavernomas is that those present with the bleed are candidates for microsurgical excision, and they are definitely amenable for excision. So how do you choose your right patient for a brainstem surgery? The patient has to be, of course, fit for surgery. Neurology does not matter. Very often we hear people say that because the patient is not fit for, is very bad neurologically, don't operate. But that's not the right thing as far as the brainstem is concerned, because we have consistently seen that once you operate on these patients and they take out the lesion, the patients do much, much better. The preferred lesions are, of course, those which are circumscribed, those which are near or abutting a pile surface, those which are dorsal or exophytic. But with experience and with technology, you could attack deeper lesions and ventral lesions. Especially for ventral lesions, you would need to think about a good approach which you could use. It is definitely, surgery is not indicated in diffuse, non-circumscribed pontine gliomas. And that is one place where I would never operate. Asymptomatic deep cavernomas are also lesions where you would not operate. But cavernomas which have bled, you have to operate. So in conclusion, brainstem lesions are amenable to surgery with very good results. But the patients need to be chosen based on clinical and radiological findings. Thank you very much, and thank you for listening.
Okay, Sridhar, excellent presentation. We're running a little late, but I'd like to introduce you to a neurosurgeon from Iraq, Baghdad, Ami Hadi. Meet Sridhar.
Hello, hi, how are you?
Hello,
Salam, كيف الحال?
كيف الحال? Thank you. Thank you very much for your presentation.
I speak a little Arabic.
In fact, very, very interesting, and it's very nice, and you are doing a great job, sir.
Thank you.
I just have a few questions, please.
Yes.
So, in selecting these patients, you said that neurology is not important.
No.
Yes. In such a case, if the patient has, say, like that case with the invasion to the thalamus. If the patient was
Yes.
in better neurological condition, will you go
Yes.
like this aggressive, or you prefer to
Yes.
go more aggressive with the less with the poor neurological, so that if it is
No, no.
like you said that it is just incubated with one-on-one, so you go aggressive and remove everything, and the idea is that if it is
I understand what you're saying.
yeah, sorry, thank you.
Yeah, I understand what you're saying.
Yeah.
In my opinion now, I think these lesions have to be operated aggressively, okay, irrespective of neurology, okay? If the patient is neurologically good, it is better because the patient would do well post-operatively. If the patient is, like I showed, E1, M1, then what would happen is to come out. But my point is, bad
Yes, the challenge is
neurology
with the better
should
neurology.
not say, you should not say that you should not operate. Neither should you say you should not operate if there is good neurology.
Thank you.
Okay.
Another question, please. And for the diffuse type, you even biopsy is not needed. You immediately send for radiotherapy.
No. That diffuse pontine glioma,
It will bleed definitely.
without a circumscribed lesion,
Yes.
that is not for surgery except maybe a shunt or an endoscopic third ventriculostomy. That would be perhaps the only type of brainstem glioma I would not operate.
Thank you. Another question, please. Regarding
Yeah.
gamma knife, the role of gamma knife, and where you decide to send for gamma knife or for surgery.
Gamma knife for what?
For a brainstem lesion, like a
For
carcinoma
brainstem lesion?
or a tumor. Yeah.
No. I'm sorry. I don't believe in gamma knife as far as the brainstem is concerned.
Because of the inflammation that occur after radiotherapy, the worsening.
That is number one.
Yes.
Yes. And if a cavernoma has bled, especially in children, those need to be taken out. Because your gamma knife is not going to show its results for a very long time.
Yes, that's right.
Okay.
Yeah. So I would not wait and do gamma knife.
Yeah. Another point, and as I said, that do you use a safety borehole, like if
Yes,
the
always.
supracerebellar approach, the early in the presentation, you see the aqueduct, it's clear, and that's on. You didn't put a shunt or an ETV, or an.
No,
you just
if there is hydrocephalus, I do either a shunt or an ETV if I have time.
Definitely. Yeah.
If the patient is very critical, then I put a external ventricular drain tube intraoperative to reduce the pressure when I open the posterior fossa.
And if there is no hydro, you put a safety shunt or no? It depends on what you see.
Yes, safety burhole. A safety
burhole.
Safety burhole always. Safety burhole always.
Yes.
Okay.
I'm so thankful for your service. It was very interesting and very knowledgeable.
Thank you.
Good knowledge for us. Thank you very much.
Yeah, thanks for coming,
It's
Kumar.
our honor.
Natarahan, do you have any questions or comments? You're muted, Natarahan. You're muted, Natarahan. That's okay. That's okay. We've kept him waiting for his talk. We're a little late.
Yeah.
But, that's okay.
Hi, Muthukumar.
That's okay. Thank you, Doug, very much, Sridhar. And we'll talk about that neurocritical conference later. And it was a pleasure meeting you, and thank you for your time and your dedication.
Thank you.
Okay, we'll sign off for this one, and we'll start the next one. Thank you.
Yeah.